Good evening, friends. Welcome to another edition of IMA Haryana Academic Fiesta. And today we'll be discussing a burning topic of discussion, COVID in 2025. And new strains and new cases are emerging very fast in India. And we have none other than Dr. Sushila Kataria, who had worked tirelessly during the Delta variant COVID in 2021, and she has a lot of experience of treating COVID. So she'll be guiding us about the current emerging pandemic of COVID 19 and what is latest in epidemiology, our strategy for COVID management and treatment protocol for those patients who come out positive for COVID in 2025. So I would request our president, IMA Haryana, Dr. MP Jain, to declare the session open and share his vision on academic fiesta and as well as today's topic.
Thank you very much, Dr. Pawan. And I'm really proud that for last, I think it is 10th episode of this CMEs, which we are running continuously. And I really thankful to you, Pawan, and Dr. Kavita, and all the other friends and all the speakers. This COVID-19 has re-emerged with the new strains, and which are under consideration and under examination. So right now, as I was reading in the evening, probably 7 deaths across India has occurred, and probably more than 3,000 cases has been reported. Of course, I was talking to Dr. Sushila also. Doesn't seem to be so serious, but still, when a thing has come, and Dr. Sushila has the first-hand experience of the Delta variant also. So I thought let we call Dr. Sushila only so that she can do justice with this topic with her first-hand experience in the last phase. And now she must be seeing a lot of cases of the new variant also. So I'm thankful, Dr. Sushila, for your acceptance of the invitation and for being here. And I request you to kindly start your proceedings. Thank you so much.
Thank you so much, sir. Thank you for the kind words of introduction, Dr. Pawan. And I am very thankful to IMA Haryana for giving me this opportunity to speak about this very clinically relevant topic today. I would like to share my slides, and I will speak for a few minutes, and followed by that, I would like to, then in the end, we would like to have more of a interactive session so that you can ask questions and we can have more engaging conversation. So you can see my slides, sir?
Yeah, they are visible.
All right. All right, so this is the brief perspective on COVID-19, the emerging variants and the brief history. It feels like, feels like yesterday when it came as a curiosity. It spread over the world and it engulfed the whole world into sheer panic. And we remember, cases coming from Wuhan, China, followed by that from Italy, and this kind of charts and the world COVID meter, everybody was following that very closely. So that was where it started in late 2019, like November 2019, then 2020 was the real phase, and 4th of March 2020, when I first saw the 14 Italian patients. And after that, a lot of other patients came in. 2020 was more of a curiosity and fear of Delta waves. 21 came with the promise of vaccines. And a lot of variants came. Some became variant of concern, like Alpha, Beta, Gamma, Delta, and then the vaccine was rolled out. The virus was changing at a very, very fast speed. After 20, there came the phase of 22, 21 came phase of 22, 23. The Omicron variant dominated, and it still continues to dominate. It has a very high transmissibility, but the symptoms were very mild. And by this time, population had started to be getting vaccinated. I remember first time people when heard about Omicron, and the transmissibility was 4 to 5 times more than the Delta variant, and it was feared a lot. It came first in South Africa, and after that it spread in India. So once I was driving in my car, and me and my friend were there, and then a policeman stopped us, and my friend was not wearing a mask, and he says, ये मैडम ये तो बहुत ही खतरनाक चीज आ गई है, ये तो कोरोना का भी बाप है. So there was a lot of fear, but then the anxiety settled, and we knew that Omicron is not that virulent, but it had a high transmissibility. So earlier I was wondering, why alpha, beta, gamma were being replaced every 2, 3, 4 months, and why has Omicron stayed all over and it still continues to dominate? It is a win-win situation for us as well as for the virus. So Omicron has a genetic flexibility. It has so if we had the alpha strain, the first variant, which had high transmissibility, followed by a beta strain, then a gamma one, and a delta one, which had very high virulence also, mortality was high. Followed by Omicron, and under Omicron, the number of subvariants came in. Currently, there is a variant of under monitoring, which is NB1 and LF7. So when we hear a lot about Omicron under the variant under monitoring, variant of concern, variant of interest. So in simple terms, something which is impacting public health too much becomes a variant of concern. Little less problematic is variant of interest. And under something which is evolving, we'll see how it goes. देखते हैं ऊंट किस करवट बैठता है. That becomes the variant of variant under monitoring. Like right now we are having NB1 and LF7 and XED variants. So Omicron is B11529 is the main characteristic. It has a 50 mutations, 32 on the spike proteins. So it caused a lot of immune evasion. Immune evasion means the antibody response or whatever immune response you had earlier with alpha, beta, gamma, or delta was not effective against it. It has immune evasion. And similarly, it had a strong ACE binding capacity. But Omicron survived, and it still continues to survive. The main reason for this is that the symptoms are milder. If any virus or any pathogen causes a very severe disease, the host dies, but so does the virus or the pathogen. For the pathogen to survive, it has to have a good transmissibility and a milder symptoms so that it can thrive in community. The community doesn't feel threatened by it, so it doesn't take severe public health measures, not much strict measures, not much of antiviral medication use, so the virus stays. For the community, for the human being, it is these infections provide a booster natural immunity, so that's why it persists. So because of reinventing capacity of Omicron and genetic flexibility and the milder disease, it has been in circulation from 2022 till date, and we hope that it continues. It doesn't show much genetic change, and it doesn't change its character too much. Now, the key subvariants which are right now is JN1, NB1, LF7, and XEC. So XEC is mainly in the Europe. LF5 is the variant of monitoring currently, which is increasing in number. And the NB 1.801 was detected in April 2022. It has spike mutations, and it has spread all across the globe right now. Now, recent COVID surge, what is the global trend? Where does it all start? Because we had almost forgotten about COVID, but then the report started coming from Singapore. So they first reported that the test positivity had increased to 11%, like whatever number of tests being done, 11% were coming positive. They started reporting about 11,000 to 14,000 cases every week, and the maximum active cases went around 67,000. In Hong Kong also, the number of cases increased, similarly in Thailand, China, and neighboring countries. In the last week or 10 days, the number have started to inch up in our country also. I will talk about that in the next slide. And these are the countries, especially Singapore is doing a very close surveillance of the sewage water, which actually tells about what is happening in the community and which variant is there in the community, because this is a virus which is present in the respiratory secretions, but as well as in the GI tract. So whatever is, you may underestimate numbers because patients have milder symptoms, but the concentration of the virus is seen in the sewage water. And you can also do the genetic sequencing there. So the main, and through the sewage water as well as through patients, they found out the patients were Omicron and majority were JN1. Some were NB 108.1 and others the LF7. It had mild disease, low hospitalization, and less than 1% mortality. Now, what is happening in India? The Indian scape is that as on yesterday, there were total 4,302 active cases. Of 80% have been already discharged to home. And the variants which we have found out is also in our country is also similar to what was reported in other countries. JN1 more than 50%, followed by BA2 and NB 10.8 and LF7 in few cases. What are the main symptoms? Mostly symptoms are milder. 99% of the patients are mild or asymptomatic. The most first symptom patients are reporting is a severe throat pain, itchiness in the palate. There is a disproportionate fatigue. Some patients have cough, fever may be high grade. It may last from 1 day to 3 days. The running nose is not a major symptom, but it can still happen. Some of my patients have reported sleep disturbances. Mostly during recovery phase, they say they are sleeping abnormally longer times and more times. And some patients have come up with breathlessness, and few patients who are admitted have presented with decompensation of their pre-existing chronic medical issues, like one patient presenting with atrial fibrillation with fast ventricular rate, another patient coming with acute exacerbation of bronchial asthma. Few cases do have desaturation. Currently, we have a hybrid immunity given by our vaccinations and because of the past exposure to Delta or other variants of Omicron. Now, managing what happens, how do we manage these cases? As I said, 99% self-limiting, home isolation, symptomatic treatment, get better. We're not worried about that 1%. We're worried about that 99%. 1%, be watchful. Who are those? Patients who are elderly, immune compromised, and any comorbid medical conditions, especially people with multiple comorbid medical conditions. So what do we do with these patients? If they have mild symptoms, they stay at home and we monitor their activities of daily life. If the fever does not go away in 3 days' time, we do a CRP. If the oxygen saturation reduces to less than 94 or less, or respiratory rate increases, then bring these patients to the hospital. So our guideline, the Ministry of Health and Welfare says mild cases, home isolation, only symptomatic treatment, which is paracetamol and antihistaminic. Moderate to severe cases where there is desaturation, there is tachycardia, there is persistence of fever, and patients are looking toxic, admit them to the hospital, give oxygen therapy. The patients requiring oxygen therapy would be given low dose of dexamethasone, that's 6 milligram IV OD for 5 days. If the patient is still not getting better, we can use IL-6 blockers. We have to be very careful about the tight control of underlying disease, which could be glycemic control, diabetes, because earlier we had seen that because of the excess use or inadvertent use of steroids, sugar gets hyperglycemia. Hyperglycemia can increase other opportunistic infections, bacterial as well as fungal. Now, what will be the indications for hospitalization? Just reiterating, if the patient doesn't have, the fever doesn't resolve in 3 days' time, respiratory rate is increasing, or if the patient was earlier performing of daily activities of daily life easily, but now is not able to perform, the simplest question to ask the patient is that, can you bathe yourself? Do you have any problem eating or using washrooms and all that? Or if the patient has had a normal oxygen saturation before disease, then any fall to 94 or less, or if the patient already had a compromised oxygen saturation, then any decline of 2 points should warrant us the patients to be observed more closely. If somebody has, they're not taking nutrition properly, they're uptunded or drowsy, in all those cases also we should admit. What should be the indications to use steroids? Only moderate to severe patients who are requiring oxygen and whose inflammatory markers, CRP, is increasing. Currently, we are not doing too much of D-dimer and IL-6 because we found a very limited role of these biomarkers in deciding the treatment. If the patient needs steroids, if the patient is not responding to steroids, then you're thinking of going to IL-6 blockers. So far, fortunately, that situation has not arrived. Every patient who's at home and having a sore throat, we are not encouraging them to test. And because mild cases, you're not anyway, I mean, you're going to treat it like flu only. So anybody who has symptoms should stay at home and just self-isolate themselves and take symptomatic treatment. Now come to the role of antiviral medications. We'll talk about this a little bit. So antiviral therapy, we had earlier had Paxlovid, Remdesivir, Molnupiravir. There is no role of other medications, neither doxycycline, ivermectin, or azithromycin, or in a pure case of viral infection, no antibiotic, no azithromycins, no augmentin. Thinking about these antiviral drugs, giving Paxlovid in the first 2 days is more beneficial, but it can be used in first 5 days in symptomatic patients with multiple comorbidities and elderly patients. But the problem is that Paxlovid, whatever stock was available earlier, has expired and new stocks haven't arrived in the market. For the last 5-6 days, we have been trying at different places, and our pharmacy team is also working closely. So, I mean, in due course of time, obviously, I think it would be available, but we were not very hard pressed also, but it's not available. Remdesivir is available. It has been effective against Omicron earlier also and should be used in hospitalized patients, same with multiple comorbidities. Molnupiravir, less commonly used. I didn't find it very effective also, so we are not using it. The antivirals should be used only in moderate to severe, not to be used in milder cases. And the challenge is obviously availability of fresh stock. And because these are protease inhibitors, the protease inhibitor medicines usually interact a lot with cardiac medicines. Sometimes it can reduce the level of a medicine like anticoagulants. It can increase the level of some medications like digoxin. So whenever we are putting a new medicine like this, then we have to see the drug-drug interaction very, very closely. Monoclonal antibodies came with a lot of big bang, but right now we use this bamlanivimab. We had used casirivimab and davimab earlier, but baptalovir is available nowadays. But problem with monoclonal antibodies are that they're very specific to one variant, and if the genetic mutation, which we have seen with the virus, that the virus shifts. Virus is very genetically flexible actually. So these monoclonal antibodies have to be very specific, and most of these available monoclonal antibodies have become ineffective against the new variants. So not much use. They are very high. The cost was very high, still high, and they are very variant specific and funding issues and all that. So right now, monoclonal antibodies practically of no use. Booster vaccination, again, a topic which a lot of people are asking. WHO and some countries have recommended yearly booster, but the problem is that with immune evasion, is the previous vaccine still effective? Some of the countries like Japan has come with a new vaccine, this is Zapomeron, which has the Omicron and XBB1 and NB1 effective targets. So could be effective. In Indian scenario, Ministry of Health and Welfare is still evaluating the need for a booster dose in patients above 60 years with comorbidity. No clear-cut guidelines have come. Again, there will be a problem which one to give. The nasal vaccine by Bharat Biotech is one of the candidates, that if you can give a nasal vaccine, put a local immunity in the nostrils so that the patient, this becomes more as a barrier for spread of infections and catching infection. This, whether there is a need of annual boosters, whether it should be a bivalent vaccine or a polyvalent vaccine, it is still to be seen. Whether this particular wave will cause any significant impact on the public health, that will decide. In future, we might come up with a flu vaccine and a COVID vaccine together. All right, so this is the data from May 21st till June 1st. I have been able to interpolate, and similar trends continues in last 3-4 days also. So like we started with total 3 RT-PCRs, 2 came positive on 21st May. So total 50 samples have been done in this period, and there was about the 100 samples were done, and there was 50 samples which came positive. So about 50% test positivity, but we can't say that in general public it is as high, because all these cases have been symptomatic. It's not done in asymptomatic cases. These have been the trend on daily basis of the test positivity, COVID test positivity. I would like to ask, to speak about 2 cases. Most of the cases out of these have been at home and recovering very well. Currently, total 8 patients are admitted. Some patients are admitted because their chronic medical condition got decompensated. Somebody had a bronchial asthma, came with a very wheezy chest and 1-day fever, turned out COVID positive. So they are in hospital because the asthma itself would have needed the hospitalization. A few patients were operated and post-operatively started with fever. So as a workup for the cause of fever, they were found to be COVID positive, but the lungs do not show much of COVID changes. These are 2 patients which are interesting, which I thought I'd like to show you. One is this 80-year-old lady, diabetic, hypertensive, coronary artery disease. She was visiting her sister here. She was running high-grade fever for 3 days. She became breathless when the sister brought her here. So we did a COVID test. She required oxygen in the emergency, 2-3 liters. The oxygen demand went on to increase to 6 liters. Then we did the CT scan. COVID came positive after 24 hours. She required nebulization, steroids, antiviral drugs we did not give. She is improving and hopefully she'll be discharged tomorrow. But this shows that yes, some patients are showing lung changes. Another patient is this one, a 71-year-old male, known case of CAD, coronary artery disease, had atrial fibrillation, came with a fever and breathlessness and palpitation. In the emergency ECG showed atrial fibrillation with fast ventricular rate. Patient got admitted with the cardiologist, but because the patient had fever, so this was sent. And this is the patient who shows, this CT would remind you of the times in April 2021, isn't that? So this patient has significant lung involvement. It is being treated with remdesivir and dexamethasone and oxygen. Patient is clinically doing well, but the lung involvement is pretty extensive. So the key point is that COVID persists with Omicron subvariant. We have low case burden, robust immunity, vigilance still is needed. The treatment is mostly symptomatic, 99%. 1% may require antiviral and corticosteroids. I don't see any role of monoclonal antibodies. For prevention, booster dose may be to the high-risk group, but we have to see which particular vaccine can be given. And for future, we have to stay very vigilant, very alert. We continue to have surveillance of during all seasons. Whenever the flu or any respiratory infection comes, we should be able to pinpoint which particular, whether it is influenza, whether it is adenovirus, rhinovirus, or whether it is COVID variant. And we, in times to come, maybe on the vaccine also some decision would be made. Thank you very much. I am happy to take questions on this now.
Thank you, Dr. Sushila. It was again a wonderful coverage of the recent emergence of this epidemic. And probably we have reported around 4,500 cases till date. And low reporting is because we are having low testing also. So it is just a tip of iceberg. I think the numbers would be much high, but because it is not such a variant of concern as defined by WHO. So probably we are not much worried in healthy patients, but definitely in patients with multiple comorbidities, it could be a cause of concern. Ma'am, my question would be basically, as we know that first 4-5 days are periods of viremia, and then there is interplay between immunity and the viral load. and probably it is the hyperimmune response of basically body which causes most of the damage in the lungs and other tissues. So when to start antivirals in those patients who are having multiple comorbidities, number one, and when to start steroids to curb the hyperimmune response of COVID uh, uh, sick patients. So these are two things. Thank you.
These are very, very important and relevant questions. You are right. First phase, about 5 days to 7 days period of viremia, followed by the immune cytokine response or immunological response of the body to the virus, which goes haywire. So I think in patients who are extreme age with multiple comorbidities, if available, the antiviral drugs, something like Paxlovid, which is oral, should be initiated as early as possible. Remdesivir we can give up to first 7 days of illness. Afterwards, it has not much help, and Paxlovid is usually first 5 days to reduce the hospitalization and the other effects. Steroids to be initiated whenever patient goes on oxygen support, and we should monitor the CRP. And if the CRP is increasing, then I think it's time to start steroids.
Thank you. Any other question?
Yes. Madam, Novavax vaccine, they have manufactured a vaccine against JN1 variant in 2024. And that is the only one available for JN1 variant. But this is not available in India. And second thing is you talked about nasal vaccine by Bharat Biotech. This was not available even when it was introduced. It was not available. So is it available in the Gurgaon?
No, sir. It's not. I mean, it was available briefly with us, but now it is currently we. I think like all the hospitals, there was not much demand, so we also closed our COVID vaccination center and converted it into an OPAT where antimicrobial outdoor patient antimicrobial was given. So yes, I mean, as you said, and everybody knows that this is not so much of a public health problem right now, but if it becomes, then probably the manufacturing of these vaccines and availability would be, and that's what I think the ministry is observing.
Yes, madam. The Novavax vaccine was at that time it was being manufactured by Serum Institute of India, but from the original strain only. They have
We
now
did have an
modified.
Omicron one, and somebody came, and these guys, they marketed it strongly, but by that time the wave had already dampened, and there were not many takers for that.
But currently, it is not available in India. It is not manufactured in Serum Institute, so they will have to import, or the Serum Institute will have to
Do some
collaborate.
do some collaboration, yeah.
And if the disease,
Ma'am,
if the number of
sorry.
cases rise rapidly, then the government of India may consider developing the vaccine again, or Bharat Biotech may take the initiative. They have the basic facility. Only they have to get the virus and kill the virus and then make this killed vaccine.
Ji, sir. I would like to add one more practical point here, not about the vaccine, but about the disease itself. Now you'll see most in the offices and in hospital, people will start coming positive, and then there becomes a HR problem. How many days of leave is to be given to that staff? So I think the Indian guidelines have not been revised after 2022, where it says 7 days from the time of testing. But the CDC guidelines have been revised recently, and they say total 5 days from symptoms, and out of this, the last 2 or 3 days should be fever free.
Ma'am, you said that preventive booster can be taken. What do you mean by saying this thing? Preventive booster means what?
No, I haven't said preventive boosters, sir, but I said that boosters, the government has to decide booster every year, like we're taking for flu, then do we need similarly an injection for COVID also? Because COVID is also going to stay here with us, and it might change its shape and all that. So do we need a vaccine for COVID-19, and which needs to be updated every year? That time only will tell, sir. We do not have any strategy right now, and this is something which the government and WHO will take call. WHO, I mean, every country is making their own rules. In India, we do not have any policy right now. After the 2 doses and a booster, yearly booster, we are still, we haven't come to that level.
Ma'am, what is the role of herd immunity which we gained from Delta infection as well as Omicron infection, and currently by exposing ourselves to the new variants of Omicron, probably India will develop herd immunity, and it will be, I think, it will be protective for most of our patients or most of our population to be precise. So probably herd immunity will play a big role by having this mild infection like flu, and probably we won't be requiring vaccination for the general population. Might be for those patients with multiple comorbidities or elderly patients. Definitely, we may include it in our future guidelines, but currently, I don't think that it is required for the general population.
Agreed, sir. Agreed. Very much agreed. And because, it's a lot of work to develop a vaccine. And if there are not many takers for that, then it is not very cost effective for the company also. So they don't also want to invest into it. Flu is still people, a lot of people take it. It's more like everybody takes a flu vaccine. That's why every year a new flu vaccine is developed depending upon the strains which are circulating in the end of the season.
Yeah, madam and Dr. Pawan, I think this COVID vaccine is not having much of the herd immunity as far as because most of the viral, especially inactive vaccines, they do not have much of the herd immunity. So probably it has the individual protection, but as far as society is concerned, I think it is not very good. And now it is almost 2 3 years. So now, as you have already spoken, that neutralizing antibody titer are also declining. So definitely, if this problem escalate, then definitely probably government has to think about the vaccination also. And one thing more, in your personal experience or the other places experience, or what is the role of this infection in the pregnancy, especially at the time of birth or around the birth, and a pregnant lady as well as in the newborn. So, do you have any idea about that with this particular strain, ma'am?
Uh, I do not have a first-hand experience because our pediatric team and the gynae team have not faced so much of problem, at least in this, because it's the whole problem has started in the last 10 days only. So right now, but in the experience from Singapore and from Thailand, if I know that, so this particular variant doesn't increase the severity in pregnant women as the Delta wave was doing. So it is not doing that. But yes, if the mother, as far as the newborn is concerned, I think transmission to the newborn, if the mother is infected at that time, is a possibility. But I at least I haven't come across any reports where premature deliveries or mother's health been compromised or the newborn child's health been compromised.
So that also has a lot of relief if it is not probably worsening in the pregnant ladies, and if the neonates are not infected, then probably it will be good. But let us see how it evolves and how it present in the coming future. We have to keep our finger crossed about the evolution and seriousness of this particular strain. But till then, we have to be rightly said that we have to be very cautious and we have to put on our guards as before.
Truly said, sir. We have to be very vigilant. And as I had shown few cases also, so there, even if it is 1% who requires hospitalization, my suggestion is that all those patients who are getting admitted to the hospital with SARI, which is severe acute respiratory infections, should be tested and then treated accordingly. Otherwise, for the milder cases, I think what we do for a flu, home isolate, symptomatic treatment should be enough.
Any more question from anybody? Dr.
Madam,
Sushila?
can you put some WhatsApp message every week? What is the latest in your hospital, Medanta? Or
Yes, sir. If something, any trend changes, which all of, I mean, would be important to my colleagues, I would do that, sir. Or maybe through Dr. Goyal and Dr. Jain, I would get it
Yes, sir.
communicated to others. Yes.
Thank you so much. And you have really submitted the topic very well and in very brief, but taking everything into consideration. Thank you so much for delivering the lecture. And
I think there is a comment. There is a comment in the chat box. Kindly send 5 days home isolation, out of which 2 days fever-free guidelines. So it is from Dr. Subhash.
So this is a guideline from CDC, Dr. Saab. So we, and in Medanta, matlab, if my staff gets unwell, this is what I follow. So this is a CDC guideline, and this Ministry of Health and Welfare guidelines haven't changed from 2022, which mentions 7 days. But I think it is practical right now to reduce it to 5 days. And in my hospital, that's what we do.
thank you so much, ma'am. And I invite Dr. Dhirendra Soni, our Honorary Secretary General of IMA Haryana, to put a vote of thanks. Dr. Soni, please.
Thank you, ma'am, Dr. Sushila, for a nice presentation, for updating us with the new threat. And thank you again for reassuring us that it's not that serious. Let's be on our guard. And thank you for this. Thank you, all the participants. Thank you, Dr. Pawan, for giving us a weekly dose of.
Thank you, sir. Thank you. It was 18th session of IMA Haryana Academic Fiesta, and I will ensure our president and secretary to continue it throughout the year. And we have more exciting speakers to come in the coming episodes of this IMA Haryana Academic Fiesta. Please spread the word, because a lot of effort goes behind choosing the speakers, and the speaker also puts a lot of effort to present their topic, and it is definitely very beneficial for all the members. So please spread the word. Please spread the word in your local branches, so that more number of participants can take part in this academic feast. Thank you everyone for your time, and thank you especially Dr. Sushila for a wonderful talk. Thank you very much.
Thank you, sir.
Dr. Pawan, as soon as you post it on the YouTube, please post it on the WhatsApp
Yeah.
group.
Today it was live on YouTube also. We have made it live on YouTube regularly. We'll make
Okay.
it regularly live on YouTube also. If number of participants cross 100, then probably we'll be having more participants on YouTube. It is
Thank
available on
So it is
IMA
available in
Haryana
YouTube.
YouTube channel
Okay.
regularly. It is live.
Okay. Thank you. Thank you.
Thank
Thank you, sir.
We
Thank you.
look
Thanks, everyone.
more sessions with your expertise in coming future.